the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.
So, good morning, Oscoli. We are pleased to welcome. I am Dr. Nguyễn Khôi Việt from Hanoi, Vietnam, and I will Professor Teruhito Mochizuki. Please welcome. In this section, there are 4 speakers from Korea, New Zealand, Great Britain, and Netherlands. Because time strictly, we will have a discussion Q&A part at the end of the session. Thank you. In order for the conference to begin, I would like to introduce Professor Byung-Uk Choi from Korea. He is a professor director of Department of Cardiovascular Radiology, Severn Hospital, Yonsei University. He also a peer reviewer for SCI and SCIE. Today, he will present a topic about parametric mapping technique and issue. Please welcome, Professor.
Thank you, Chairperson. Good morning, ladies and gentlemen. The definition of parametric mapping is a process where a secondary image is generated in which each pixel represents a specific magnetic tissue property, T1, T2, or T2 star, derived from the spatially corresponding voxel of a set of co-registered magnetic resonance source images. Parametric mapping methods such as T1 and T2 mapping are quantitative MRI techniques that provide a pixel-by-pixel representation of absolutely denominated numerical T1 or T2 properties expressed in units of time. Parametric mapping is particularly useful for the evaluation of acute myocardial injury, myocardial infiltration, and heart failure of unclear etiology. Before I talk about parametric mapping techniques, which are represented by T1 and T2 mapping, I'm going to start with late gadolinium enhancement. The concept of LGE was first introduced for and applied to myocardial infarction. But since we knew that LGE could be present in any kinds of myocardial damage, including inflammation, necrosis, or infiltration, we have expanded its application to non-ischemic cardiomyopathy. Cardiomyopathy is a group of myocardial diseases with various etiology. Then myocardial tissue characterization with LGE have become an essential part to classify myocardial diseases, diagnose the etiology, and predict the patient's outcome. However, let's look at this LGE case. There is a diffuse myocardial enhancement of the left ventricular myocardium in the left-sided picture. Is it a real pathology representing diffuse fibrosis? When we adjust the inversion time from 280 milliseconds to 220 milliseconds, most enhancement disappears. As you noticed, correct selection of inversion time is very important for correct interpretation of LGE. But let's think about real cases with diffuse pathology. For example, diffuse fibrosis causing real diffuse enhancement, or mild fibrosis which does not accompany apparent LGE, or when we need to quantify the enhancement intensity. T1 and T2 mapping technique is a promising solution for these cases. It provides absolute value as time, so the measurement is quantifiable. Native T1 map represents a composite signal from both the intracellular and extracellular compartments. Post-contrast T1 value is affected by many factors such as contrast kinetics, hematocrit, so it does not serve as a reliable biomarker. However, ECV fraction can be calculated from pre- and post-contrast T1 maps with this simple formula, and ECV is not significantly affected by contrast kinetics. Research is actively ongoing about myocardial tissue mapping with or without contrast enhancement regarding early diagnosis and the prognostic value. Parametric mapping is widely accepted as an excellent tool for non-invasive myocardial tissue characterization. However, there is a big obstacle for widespread clinical use of parametric mapping, which is the lack of standardization of techniques. In consequence, normal reference value is usually acquired in a specific local setting, then can be applied only to intended local data acquired with the same method. Without interoperable data, study for clinical utility of parametric mapping is not effective. In addition, the technology has been rapidly evolving. I'm going to talk about basic techniques of T1 and T2 mapping. Let's see how to do T1 mapping first. Two types of magnetization preparation pulses are used for T1 mapping. First, saturation recovery pulse always non-selectively saturates G-directional net magnetization to 0. So there is no need to wait recovery of a longitudinal magnetization, which is the reason why saturation recovery-based T1 mapping technique has high accuracy. However, saturation recovery preparation pulse produces lower signal to same noise level compared to inversion recovery preparation pulse. On the other hand, as you can see in this graph, dynamic range of T1 relaxation process when we use inversion recovery pulse is twofold of that of saturation recovery pulses. However, standard inversion recovery measurement requires a long repetition time, approximately 5 times as long as the T1 value, in order to allow complete restoration of longitudinal magnetization. If T1 of myocardium is 1 second, 5 seconds are necessary for full recovery. So repetition time should be greater than 5 seconds. If a full recovery of longitudinal magnetization is not achieved, long T1 would experience another inversion pulse when it is an incomplete recovery state. Therefore, the T1 measurement would be inaccurate. When using saturation recovery preparation pulse, that longitudinal magnetization is always reset regardless of short or long T1. Therefore, same T1 can be measured for same inversion time. These are basic things to know to understand the issues regarding cardiac T1 mapping methods. Let's look at commonly used conventional T1 mapping methods in clinical practice. The gold standard method to do T1 mapping in general is inversion recovery and spin echo combination technique. Apply an inversion recovery pulse, then acquire a T1 weight image at a certain inversion time and repeat the same process with consecutive inversion times. Then T1 fitting can be performed with either 2-parameter or 3-parameter model. 2-parameter model provides stronger signal but lower accuracy than 3-parameter model. so three-parameter model is more commonly used. This gold standard inversion recovery and spin echo measurement technique is not practical, even though it provides good T1 samples. Pixel-wise mapping is not possible, and scan time is too long to be feasible in real practice, especially because samples are required for at least 6 to 10 time points along the T1 recovery curve. In 1970, Luke and Lacker proposed an efficient method to reduce the scan time using a continuous and periodic train of radio frequency pulses after the inversion pulse. Due to a number of factors, including the type of readout sequence and tissue characteristics, longitudinal magnetization recovers steady state quicker than undisturbed equilibrium magnetization, which is called apparent T1 or T1 star. T1 star is usually less than the true T1. T1 star could be and should be corrected by applying a Luke-Lacker correction with this formula. So, Luke-Lacker method achieves better practicality, but still pixel-based mapping is not possible for moving heart. Modified Luke-Lacker inversion recovery, so-called Morley technique, is the first method to enable T1 mapping possible for moving heart and in clinical practice. The Morley technique uses inversion recovery preparation pulses, single slice, single shot readouts within a cardiac cycle in a specific phase throughout one breath hold, following which the images are sorted into a single data set according to consecutive inversion times. The original Morley was a 335 protocol. The unbracketed numbers indicate the number of images acquired after every inversion pulse, and the bracketed ones indicate the numbers of oral intervals for T1 recovery. So Morley technique fulfills all three requirements for cardiac T1 mapping. However, other issues are raised regarding accuracy, especially in fast heart rate and still long breath holding time for 17 heartbeats. According to a phantom study, T1 value measurement were quite different according to heart rate, and modification of original 335 Morley protocol to 35 or 224 protocols, especially in long T1. But in human volunteers with a heart rate around 60 BPM, myocardial T1 was not statistically different among modifications of Morley protocol. Most practical T1 mapping technique for native T1 of myocardium now is modified Morley technique with 5-3 protocol. This protocol employs 2 inversions with 5 and 3 images acquired following inversions and 3 oral interval for T1 recovery in Siemens and alternatively 3 seconds in Philips. Images are sorted according to inversion time to perform a 3-parameter fitting. Compared to original Morley with 335 protocol, modified Morley with 5-3 protocol is less vulnerable to fast heart rate and reduces the scan time to shorten breath holding time. Shortened modified Luke-Lacker inversion recovery, so-called shortened Morley technique, is another modification of the Morley sequence. It provides a faster acquisition time within a short breath hold duration of only 9 heartbeats and is less heart rate dependent. The shortened Morley sequence does not require the full recovery of longitudinal magnetization because of the conditional data analysis algorithm. In regions of long T1, the set of samples from the first inversion is fitted using the 3-parameter model, while the samples from the first and second inversions are fitted for short T1. For very short T1, the samples from all inversions are used. Conditional fitting is a smart concept, but it is quite complex. Shortened Morley with 7 samples might exhibit increased variability because of the insufficient number of images for T1 curve fitting. Reduced precision with the shortened Morley is considered as a trade-off for reduced skin time and threshold requirement. Saturation recovery single-shot acquisition, so-called SASHA, is the best-known T1 mapping method using saturation preparation pulse. SASHA protocols involve the acquisition of 10 single-shot balanced steady-state precession images over consecutive heartbeats. The first image is initially acquired without any saturation preparation, using equilibrium magnetization as an anchor point for curve fitting, and the remaining images are acquired after a saturation pulse with a different saturation delay. Even though SASHA is a robust heart rate independent technique known as having higher heart accuracy and lower precision, according to CMR protocols 2020 update published from SCMR, modified Morley or shortened Morley should be used for T1 mapping. There are two more considerations regarding cardiac T1 mapping. The T1 weighted images acquired with T1 mapping method are magnitude images, so all the measurements present as positive values. The most difficult part of the fitting process is to find the point of zero crossing with these positive values. So fitting with the PSIR is an effective way to get an accurate curve fitting. Motion correction is another important aspect to reduce partial volume effect. Let's move on to T2 mapping technique. I'm going to briefly talk about two methods for T2 mapping. Two types of T2 mapping sequences are used in cardiac MR imaging. The first one is that I talk about is T2 preparation pulse-based sequences. The method involves two steps. The first, a T2 preparation module, and the second, a rapid imaging sequence that includes balanced SFFP or rapid gradient echo sequence. The T2 preparation module comprises non-selective 90-degree and 180-degree pulses to create spin-spin relaxation between two 90-degree pulses. After preparation, the magnitude of longitudinal magnetization depends on the degree of T2 decay. This magnitude can be adjusted by varying the duration of the T2 preparation module. There is a spoiler to remove remaining spin vector on the transverse plane. The imaging sequence, either a balanced SFP or gradient echo sequence, is run immediately after preparation. T2 preparation pulse is very similar to spin echo T2 weighted imaging, but the second 90-degree RF pulse is applied to put transverse T2 to longitudinal magnetization. With T2 preparation pulse, T2 images are acquired at time 0, 30 milliseconds, and 60 milliseconds, and the T2 map is generated by two-parameter model fitting. Double spin echo-based T2 mapping usually requires 17 heartbeats and has some limitations, including the appearance of ghosting artifacts from blood flow, which result in an increase in the appearance of bright subendocardial rims and through-plane motion, which results in signal loss and can significantly limit the clinical applicability of this method. To get images in the least motion phase is the best way to get accurate T2. The diagram is similar to turbo spin echo sequence. This technique is well summarized in a review article about myocardial T1 and T2 mapping in Korean Journal of Radiology that my team published, which is open access journal, so you can download it. And I hope it is helpful to understand cardiac T1 and T2 mapping techniques. According to general consensus recommendations published by SCMR, mapping results should include the numerical absolute value, the z-score, number of standard deviations by which the result differs from the local normal mean, and the normal range of the CMR system. The z-score is for standardization. In a study, Z-score mapping effectively differentiated between patients with cardiac amyloidosis and healthy subjects with the same diagnostic accuracy as standard T1 analysis, regardless of field strength. Z-score provides a means to compare native T1 results acquired with Mali across different CMR platforms. But in another study, Z-score would vary by as much as 11-fold. This is far above the effect size seen in even the cardiac pathologies with the greatest elevation in T1, such as amyloidosis, acute myocardial infarction, and within regions with late gadolinium enhancement, which typically exhibit only about 30% increase in T1 values from normal. The use of Z-score in the current state of the field of CMR T1 mapping with such divergent norms and standard deviations is problematic. I would like to wrap up my talk with introducing consensus statement for local reference and quality control. For research and clinical practice, a local reference range should be primarily used. If local reference ranges are not available for native T1 and T2 mapping, quantitative results should not be reported clinically. For quality control, regularly repeated phantom-based quality control is recommended and should be performed every time there is a change to the CMR system and every 3 months. Thank you for your attention.
Thank you. So the next speaker is Dr. Lot Joachim, and his title is CMR in Arrhythmia and Sudden Cardiac Death. Dr. Joachim is Professor of Radiology, Director, Head of the Department of Diagnostic and Interventional Radiology, University of Medical Center Göttingen. He has a lot of original publications as well as a lot of scientific and educational talks. And he gave a lecture at the plenary session yesterday, and his title was The Future and Challenges of the Cardiovascular Imaging. So please start your presentation.
Hello, ladies and gentlemen. Welcome to this talk about CMR in arrhythmia and sudden cardiac death. And again, thank you to invite me to give this talk to you in the Asci 2021 in Vietnam. I'm very honored for this talk, and I hope I can give you some information that you're worth your daily practice. Now, talking about arrhythmia and sudden cardiac death, actually became quite popular this year in Europe, because we had the European Championships and in soccer, and in one of the pre-rounds in a very fascinating game between Denmark and Finland, Christian Eriksen, he suffered a cardiac arrest on the field. He's a very high-scored national soccer team player in Denmark, playing for Inter Milan up to now playing for Ajax Amsterdam probably. He was resuscitated on the field by a defibrillator, went into hospital, and he received a prophylactic implantation of an ICD device, and now is well off again. Training has been coming back to athletes training a couple of days ago. Now, if you think that the ECD implementation is the end of a sports career as a high-profile active athlete, well, no, that's not true. There are a couple of athletes with non-implementation of ICD devices. One of them is Daley Blind. He's a national soccer team player of the Oranje team, so of the Netherlands. And we have in Germany Katharina Bauer, who is a world-class pole vault athlete, and she actually was an Olympionique in Tokyo in 2021. Now, if such a patient comes to you into your scanner, or the cardiologist or the doctors, clinical doctors ask you to do a cardiac MRI or imaging on these patients. So what is your job? What is your thing you have to do? The thing is, you have to rule out other causes or any causes that can be seen by imaging. The most common causes for sudden cardiac death in athletes are listed here. The good news is that there are quite some that are picked out on the regular base workup of health in the professional athletes, which usually consists of rest, stress, ECG, repetitive testing, and repetitive echocardiography, where things like valvular diseases or really striking congenital heart disease is usually detected. Even hypertrophic cardiomyopathies are usually detected by these regular workups for the athletes. Actually, this regular workup was initiated because of the incidence of congenital hypertrophic cardiomyopathies that manifest themselves as arrhythmias within the adolescence. Other changes might not be that easy to depict by echocardiography, and these are the ones you should be looking after: ARVC, myocarditis, channelopathies. Myocarditis for sure is one of the most important disease we have to look at in the MRI, because it's one of the most difficult diagnoses to be made by a clinical cardiologist alone without any imaging. This one is for sure a very, very seldom but most severe form of myocarditis, but it exemplifies the changes you might see. Yeah? You see here in this patient, he was a 20-year-old patient coming from a community hospital where these images were made. You see this finger-like late enhancement in this left ventricular myocardium. You see that the late enhancement not only includes the left but also the right ventricle. You see that it confluences and looks like additive tissue within the myocardium. These are inflammatory granulomas and inflammatory tissue, and if it's not treated fast enough, patients can go on to irreversible heart failure. Actually, this patient went on after stabilization to cardiac transplantation and now is approximately well off, of course, given his situation as a 21-year-old formerly healthy person. The criteria for the diagnosis of myocarditis in the MRI have evolved over the last 10 years. And now we have a standard defined by the Lake-Lewis criteria in 2018 that actually are composed out of two major criteria. The one is the indicator of a freshly active inflammatory change in the myocardium, which is anything that has to do with T2. So myocardial edema, either by local T2 sequences like TERM or STIR, or a T2 mapping. And the other one is the more pronounced fibrosis or more pronounced extracellular changes seen on T1 imaging, either by T1 abnormalities, by LGE if they're more focused, or more diffuse in ECV, so extracellular volume estimation by T1 mapping plus contrast agents. And there are supportive or minor criteria which focus more on collateral damages like pericarditis or systolic left ventricular dysfunctions. Especially the minor criteria are reversible, and usually in the major criteria, of course, the myocardial edema will vanish once the acute phase of the myocarditis is gone. Talking about changes by T1, so extracellular volume changes, reversibility is still in debate. Now, if you have a patient like this patient who has evidence of focalized myocarditis typical changes in the left myocardium. You see on this phase-sensitive inversion recovery sequence here, 4-chamber view, you see this dent-like or this finger-like late enhancement within the epicardial myocardium. The question is, what is the prognosis? Or does it have an effect on the prognosis of this patient? In terms of going back to normal life and in terms of, as an athlete, go back to perform his or her sports. There has been extensive discussions about this theme, and one of the publications that have an impact is this publication by Dr. Greulich. He's from the Stuttgart group of Sechtem at that age, and he actually published this study in 2020 in the Journal of the American Heart Association. They had a registry about 250 patients, and 183 were included in this long-time follow-up. They were all biopsy-proven myocarditis and had a 10-year follow-up. And some truth about these patients is that patients with myocarditis without late gadolinium enhancement had an overall very good prognosis. And patients who had a late gadolinium enhancement in combination with the clinical picture of myocarditis, they had a worse prognosis towards development of cardiac symptoms, towards decrease in physical performance. And there seems to be a tendency that lateral late gadolinium enhancement seems to be a little bit better than septal or anteroseptal intramyocardial late enhancement. But this is not really not bulletproof, but it's like an observation by Mr. Greulich. Another theme that is very up to date right now, of course, is the link between myocarditis and COVID-19 infections in athletes, but also in normal persons, not so athletics, so like me, not really prone to sports. So there are some observations, of course. So myocarditis for sure is one of the most important causes for sudden cardiac death during physical exercise. This is not only true for COVID-19, but for all myocarditis. Myocarditis for sure is one of the manifestations of COVID-19 infections. We know that now after 1.5 years or almost 2 years of the epidemics, and about 90% of the athletes with mild or no symptoms of the COVID-19 infection show changes in CMR. They look like myocarditis or pericarditis, but we don't know whether they are really linked to COVID-19 specifically. A publication by Clark et al. From Nashville, they suggest this. There is a counter publication from 2021 in the JAMA Cardiology by Kim et al., who actually have the main message, and the main message is that not every LGE we see in COVID-19 patients is due to COVID-19 patients. That's because we have limited access to a big population screening. And we know that even without COVID-19, that the significance of myocarditis-like CMR findings in the asymptomatic patient who has not a history of acute myocarditis in the last 1 or 2 years is pretty much insignificant. And so they tell in their research letter in JAMA Cardiology that the indication of the CMR should be really tailored to the individual, and they suggest that you need to have an elevated troponin level of at least 48 hours after the last exercise before you think about performing a CMR. And especially in athletes with a low probability of having a myocarditis, even if they have a positive CMR, they suggest that they should be allowed to go back to play after excessive or extensive, not excessive, extensive maximum effort exercise tests. And if they are normal and there are no symptoms, they should go back to the place. So myocarditis is a big theme. Myocarditis is a huge variety, and as you will see, you might have overlaps with other diseases. Another group, which fortunately is usually detected at the regular screening of the athletes, is any form of hypertrophic cardiomyopathy. What you should know about hypertrophic cardiomyopathy is that it's usually a congenital heart disease. So it's inherited or genetically manifested cardiomyopathy. That means it develops during adulthood. So it's very important to very early monitor these patients because they can actually develop their hypertrophy, and the problem with the HCM is malignant arrhythmia. This is a patient with cross left ventricular hypertrophy. You can easily see it here on these images with a pretty symmetrical hypertrophy of the whole left ventricle with a special tendency in the septal area with this light dots here of late enhancement resembling fibrosis within the interventricular septum. If this septal hypertrophy enlarges, the HCM can go further to the obstructive version of the cardiomyopathy. So this is a hypertrophic obstructive cardiomyopathy, and very characteristic here is, of course, the subvalvular, this is the aortic valve, the subvalvular jet, which resembles the stenosis in the left ventricular outflow tract, and with that combined is the systolic anterior movement of the anterior mitral valve leaflet. And this all septal hypertrophy SEM, the jet subvalvular jet makes up the obstructive component of the hypertrophic obstructive cardiomyopathy. And you might see like this a very extensive fibrosis within this septal hypertrophy. And we also use this for the planning of dedicated ablation of the myocardium here to reduce the thickness of the myocardium, so the obstruction is ameliorated. Now there has just been an update on the AHA criteria for the diagnosis and management of hypertrophic cardiomyopathy, and they focus actually the management on any changes that increase the likelihood of malignant arrhythmia, so sudden cardiac death. And they found about 4 areas of 4 criteria which we have to look at. The first one is the wall thickness, about more than 30 millimeters or 28. This is a kind of a borderline thing in any segment within the left ventricular chamber. In pediatrics, not so easy because in pediatrics the heart is enlarging, it's growing, so we're not looking at absolute values, but in the deviation of the normal. And here we use the SAT score about more than 20 or more than 10 in conjunction with other risk factors. Then, of course, second criteria is the left ventricular dysfunction. Any left ventricular apical aneurysm, independent of any size, is one of the criteria that is a risk factor for sudden cardiac death, and extensive diffuse or focalized LGE, which resembles more than 50% of the LV mass. So I just read it from the slide. But this, again, is not proven for the pediatric patients because we do not have any extensive and bulletproof data for pediatric patients in hypertrophic cardiomyopathy. But it's an inherited disease or a congenital disease. So the pediatric patients have a very focus because it has. We have to find the point where medications and or other measurements can be initiated to keep the myocardium from developing arrhythmias. Now, if you look at the flow sheet, how to handle those patients, you see that for class 2B indication, we have an risk assessment CMR if the echocardiography doesn't work every 3 to 5 years, and that's approximately what we also do. What we also see is this little remark here, the 5 with the screening ECG and echo for relatives. Not really symptomatic, but first degree relatives to patients who have a diagnosis of hypertrophic cardiomyopathy. Why is this so cumbersome? Why is this so extensive? Because sudden cardiac death cannot be predicted. So these patients are to receive a monitoring, and it depends on their age, whether it's every 2 years or every 3 to 5 years, a lifelong. This is a chronic disease. So they receive this staging or this surveillance interval for years. Another point where we have to look at is the development of an arrhythmogenic right ventricular cardiomyopathy or any other type of right ventricular cardiomyopathy. ARVC is just one out of a huge variety of right ventricular cardiomyopathies with very different genetically bases subsumized under right ventricular cardiomyopathies. This is an quite extensive example, which nicely resembles what we have to expect. You see this excessive right ventricular dilatation. You might see systolic outwards movement in the sense of a right ventricular aneurysm formation in the free wall of the right ventricle in this patient who has a proven ARVC at the age of 12 and then restrained from seeing a doctor for about 15 years, and with and in his mid-20s now comes back because he has obviously an outward right ventricular insufficiency. Interesting in this case that that we have a total displacement of the right ventricular myocardium by fibrous tissue in this case, besides the heart, the enlargement of the right ventricular volume. As you will see, that is late enhancement is not a major criteria for the ARVC. The ARVC criteria, they focus on a functional assessment, which is usually done on a visual base. So feature tracking is not yet in the guidelines. So a pure visual analysis of the right ventricle, whether you have any akinesia, any dyskinesia, any dyssynchrony, so not regular contraction of the right ventricle, plus a volumetric criterion, which is the dilatation of the end-diastolic volume index or the reduction of right ventricular ejection fraction. If it's not so bad as less than 40% EF reduction, it's a minor criterion just listed here in this table, and you have to apply these criteria to your data sets, which you can do actually right now. So this is one example. This is a 30-year-old male who has some mild symptoms of palpitations, and we know him for quite long, and he has inherited positive genetics for ARVC. So biopsy proven, and actually we monitor him every 5 to 6 years, depending on his symptoms. And these are the last two. Actually, I left out one, but these are two examples of his monitoring in 2013 for JAMA-View. Pretty good ejection fraction on the left side, and also on the right side, not really remarkable. Now in 2021, same view, you see that the heart has enlarged. You see that there has a small aneurysm formation here, some very subtle dyskinesia on the right ventricle, on that side here, on the free wall, or in the near septal wall, and at the free wall here in the right ventricular outflow tract detection. If you look at the volumetry, so this is one of the major criteria. We have a new onset of dyskinesia, also of right ventricular aneurysm, so dyskinesia, myocardial dyskinesia. And we are looking at the major criteria for the volumetric parameters, which is the end-diastolic volume index of the right ventricle and the ejection fraction. Both have dilated. So while in 2013 we were not so sure, he received the biopsies in before, so we knew he has an RRVC. He is now the full-blown major criteria for the presence of an arrhythmogenic right ventricular cardiomyopathy. Now his follow-up has actually stopped because he received, just a couple of days ago, he received an intracardiac defibrillator. And so we actually follow them up not with the MRI anymore, only if we have, for example, an acute incidence of overlapping myocarditis, then we could actually use him or put him back in the MRI. Otherwise, he will be followed up by echocardiography and or by CT. Now, this patient is a 61-year-old, so she's way out of the normal age range where you would expect the first manifestation of an RA-VC, which is about 15 to 30 years. This is about approximately the time where you think that the syncope and palpitation manifest themselves for the first time. What is here interesting is because you see all the major criteria you want to have. You see here very nicely the dyskinesia, the focal we call them microaneurysms of the right ventricle because they're little blebs here, very small ones. And you see what we often see, that's why I put it in here. You see that the imaging is distorted by her arrhythmias. That we see late enhancement here is interesting, but it's not the criteria for ARVC, but gives you a hint what happens to the myocardium in the moment. So we see here a strictly right ventricular late enhancement, which is now kind of evolving that right ventricular cardiomyopathies might have late enhancement, especially in the diaphragmal wall or in the free wall of the right ventricle. So the initial diagnosis with this patient was the question of ischemia. We did perfusion on her. It was normal, given that really quite extensive arrhythmias. And we have an unspecific LGE. It's consistent with the right ventricular cardiomyopathy, although she has all the major criteria for ARVC. So she has a new onset or a new detection of dyskinesia, and she has a dilated right ventricular index of 106 milliliters per square meter and an ejection fraction well below 30. So all in all, she has, from that side, the MR criteria of ARVC, although she's a little bit too old for the first manifestation. Another example, this is a patient first actually symptomatic with an initial syncope and arrhythmia in the school, during school sports, typical situation. Came to echocardiography. Echocardiography actually looked at the right ventricle and said it's dilated, question of ARVC. So this was in 2016. And we did the image on him, and we see that, we see that, or what you don't see because it doesn't run, you see that we have, for a 12-year-old boy, we have a quite large right and left ventricle, but especially the right ventricle is pretty much dilated, and you should see some dyskinesia here. In addition, what really surprised us was that he has signs of an acute myocardial damage, as a T2 term, shows this high signal intensity here within the septum. He had quite an enlarged ECV, so extracellular volume, in the T1 pre and post gadolinium, and he showed some very interesting intramyocardial and epicardial late enhancement in the four-chamber view late gadolinium enhancement. Looking at the major criterion for ARVC, he does have them. He has a dilatation of more than 110 milliliters per square meter, so he's positive for the major criteria with a reduced ejection fraction of 20%. So what we have here now is kind of two things. The left ventricle is pretty much well preserved, a little bit borderline dilated, but we have this late enhancement, you have this acute damage, so this actually is an overlap. And this overlap was proven by repeated biopsies, and this patient has two specific gene mutations in two loci, the PKP2 and DSG2, location, which makes the diagnosis of a familiar or inherited ARVC very probable, and the histologic workup also relieved or showed an active myocarditis in this position. Now here it comes. Okay, next patient, and next pathology. The diagnosis of a non-compaction cardiomyopathy is another tricky diagnosis. I'm sorry to just offer you tricky diagnosis, but that's how life is in sports medicine and in the question of sudden cardiac death and arrhythmia. These are two different patients. On the left side is a 14-year-old girl. She has ECG changes and it was a little bit symptomatic, but not really. So she was rated as non-symptomatic. And on the right side, you have a 49-year-old male who actually showed up with arrhythmia and this initial syncope out of nothing. And both show same type of changes. If you look at the left ventricle here, you see this intense trabeculation, very nicely seen here in the vertical lung axis between the two papillary muscles. Here in the 14-year-old girl, the small heart and the bigger heart here of the 49-year-old male, you see similar changes. This could be a non-compaction cardiomyopathy. What are the criteria? The criteria are oriented in the publication by Grothoff, and at that time in Leipzig with Matthias Gutbellet, and published that in 2012. And it's a combined combined criteria. The first is the volumetric mass or volume of the non-compacted myocardium measured in end-diastole. This is important. And we actually use different diagnostic criteria. Those from Grothoff and Jacquier, and Jacquier et al., they have a different cutoff point for non-compaction cardiomyopathy in terms of how big is the ratio of non-compacted cardiomyopathy in comparison to the total left ventricular mass. Grothoff says 25. Jacquier says anything larger than 20%. So within that area, it looks like a non-compaction cardiomyopathy. And the thickness index by Stacey, and this thickness index by Stacey is remarkable because they do not use diastolic short axis views, but in systolic short axis views to measure the non-compacted to compacted myocardium ratio. So if you apply these to our two cases, you'll see different results, and this is how actually Grothoff published it. And the interesting part is that most people know that these two are the major criteria. So the total mass of non-compacted cardiomyopathy should be more than 15 grams per square meter, or more than 25% of total LV mass. But they also, Grothoff and Gutbellet also pointed out that trabeculation must be much intenser in the mid and apical left ventricular region than on the basal parts, because the apical and mid ventricular portion, they show some trabeculations in the left ventricle because of the papillary muscles. So again, doing the application of these criteria to our patients, and we see that on the left side, the young girl, she has a borderline result, because the non-compact cardiomyopathy has not yet established, or not yet hypertrophied enough to be of to get the cut line of the Grothoff criteria of more than 15 grams per square meter. But even though we have the percentage of the left myocardial mass, it's 21%, so it's Jacquier pathologic, and the Stacey criteria of division of compacted and non-compacted myocardium are borderline positive. On the other side, the older male, actually, he has a full-blown non-compacted cardiomyopathy seen by all criteria. Is this now a non-compacted cardiomyopathy or not? Well, we do not know, but again, this is a growing girl, and it might be that this girl will have the full-blown criteria within 2 or 3 years. And there is another drawback or another pitfall. We know that patients with African ethnicity, they have huge topical lesions. And this is especially important for professional soccer players and professional basketball players, because once they develop arrhythmias out of any reasons, which could be a small myocarditis, small flu, some cold, there are typically those that are pushed into that non-compaction picture, but do not actually have non-compaction cardiomyopathy, because for them it's physiologic to have a top-regulated left ventricle. You have to have some experience with that. And now there's the last group is the channelopathies. The channelopathies, unfortunately, is one of the major parts, especially in athletes, which you cannot really depict from the normal routine checkup of the athletes. These are diseases of natrium channels or of sodium channels within the myocardium. And you can usually depict them on the ECG once the Brugada syndrome has established themselves with a full-blown disease extent. Your task as an imager is to rule out other causes. The Brugada syndrome does not have any specific imaging changes in imaging. There is a publication, and this is kind of puzzling, by Bastian and et al. In Heart Rhythm 2017, who actually said that they had 2 observations in patients with Brugada syndromes, small patient series, where they said they had punct-like, very focused puncture-like late enhancement in the septal areas, or a right ventricular dilatation. So this really doesn't make life easier. And this is a patient who actually has a proven Brugada syndrome, and so seen on the ECG, and he was brought to us to the MRI in 2018 with the question, is there anything else? And so we did our imaging, and we saw that he has kind of a dilated, a little bit dilated and systolic right ventricle, but the end diastolic parameters were all good. A little bit dilated at the borderline of the end diastolic volume in the left ventricle, while I have pretty much preserved ejection fraction on the left side, a little bit reduced on the right side. But then we also saw some late enhancement, very subtle, but some late enhancement, especially in the basal infralateral wall, which we said is not really characteristic. We also had some late enhancement in here. So we were not really sure about what to do with that. So he kind of matched the criteria for ARVC, but the whole picture didn't really match to that. And we did know that he's a Brugada syndrome and not an ARVC in the ECG changes. So actually, what happened is he was biopsied and it was myocarditis. So overlaps make life complicated, but more interesting, of course. But that's reality. So you suddenly have a clear-cut example, especially in patients who are acutely ill. So they very often have overlaps, and that's one of the messages. So your job as a CV imager is, of course, to look closely at the clinical evaluation and basic workup that has to be done first. And if it's not done first, you have to initiate that it's done first, because a lot of people are diagnosis kind of crystallize once you do a thorough clinical workup and with ECG, echo, patient history, etc. And then you need a good tissue characterization. So we have one standard protocol for cardiomyopathy and myocarditis, comprising of volumetry of the right and the left ventricle. It's essential. You have to do it. LGE, T1, T2 mapping, and this all gives you a kind of a basic data set which you can work with. And guess what? There are the overlaps of the different causes of arrhythmias, and that's a problem, of course. And then you have to go to work with the clinical evaluation and the patient's history and the impression of the treatment leader. in the clinical team, and to kind of focus what is leading and what is more or less a side finding. The most arrhythmic substrates can be found by invasive electrophysiology workup only. Not the most, perhaps, but quite a large part, especially then if the non-invasive imaging is not showing any pathology. And that's it. Thanks. I hope you have some questions at the end. See you later. Bye-bye.
Okay, thank you for your nice presentation, Professor. Up next, I would like to introduce Professor Stephen Peter. He comes from the Great Britain. He is a professor of cardiovascular medicine at William Harvey Research Institute, Queen Mary University of London and Baha Center. He is also a president-elect of ESC and EACVI. And today, he will present a very hot topic right now with COVID and heart. Please, Professor.
Thank you for the opportunity to take you with me on a journey of how COVID-19 and the heart may be connected. I've recorded this lecture on the 27th of July, 2021. So this is important, and please bear this in mind when you're watching this lecture, as this field is evolving very fast. These are my disclosures, which I do not believe to represent a relevant conflict of interest for this talk. I've structured this presentation as follows. I will briefly provide the evidence of the higher risk of patients with cardiovascular disease and risk factors to suffer from severe COVID-19. Then I will cover the topic of links between COVID and acute and longer-term cardiovascular effects. The topic hotly debated is COVID-19 in athletes. Only recently have we heard about myocarditis cases following messenger RNA vaccinations. Following my conclusions, I will provide a glimpse into what is around the corner. Strong evidence emerged at early stages of a pandemic that individuals with cardiovascular disease and cardiovascular risk factors have higher risk of getting severe COVID-19. This systematic review and meta-analysis by Bay and colleagues confirmed what clinicians were seeing. Based on 51 studies with over 48,000 COVID patients, there was clear signal that hypertension, diabetes, and cardiovascular disease lead to higher odds of severe COVID or death. Despite lower prevalence of the exposures hypertension, diabetes, and cardiovascular disease at younger age, the figure shows here for hypertension that the effect of hypertension on severe COVID and death as an outcome was higher in the younger population. This was replicated also for diabetes and cardiovascular disease in this meta-regression. There was also evidence of cardiovascular involvement during the acute phase of the illness. The first report of myocardial injury with COVID-19 was from April 2020 at Renmin Hospital at Wuhan University. This report described 112 patients hospitalized with COVID-19. Of these, 14 or 12.5% were reported to have a clinical presentation similar to myocarditis. However, typical signs of myocarditis were absent on echo and ECG, except for small pericardial effusions. Troponin levels were mostly normal at admission, but increased during hospitalization in 37% of patients, especially in those who eventually died. Myocardial injury defined by elevated troponin levels was thought to be more likely due to systemic consequences rather than direct damage by SARS coronavirus 2. In November 2020, Giustino and colleagues published a comprehensive report from 7 hospitals in New York and Milan. The report included 305 patients who had both echo and ECG at admission for COVID-19. So 19% of patients eventually died. Myocardial injury was defined as elevated troponin at any time during the admission. Myocardial injury occurred in 62% of patients. Of these patients, the echocardiogram was abnormal in 2/3. The spectrum and frequency of echo abnormalities is shown on the right, including pericardial effusion, left ventricular wall motion abnormalities, LV dysfunction, RV dysfunction, and diastolic dysfunction. In another highly cited publication from the ESCVI Scientific Initiatives Committee, Mark Dweck and colleagues reported results from a prospective survey of 1,216 hospitalized COVID-19 patients from 69 countries with clinical indications for echocardiography. The study showed abnormal echocardiograms in 55% of patients. RV abnormalities were observed in 25% and were more common in patients with more severe COVID-19. LV abnormalities were present in 33% of patients and were predominantly non-specific in nature. The mechanism of this dysfunction was often not identified from echocardiography. Only occasionally were echocardiographic patterns consistent with myocardial infarction, myocarditis, or Takotsubo cardiomyopathy. CMR studies assessing myocardial injury in the acute setting of COVID-19 infections are rare, and this is mainly due to the inability of patients to tolerate the scan or for infection control reasons. This is one study providing some evidence of CMR findings in the acute settings. This is a study of 25 patients with suspected cardiac involvement, and CMR was undertaken in a median time of 3 to 8 days after diagnosis of COVID-19, detected acute tissue abnormalities in up to 96% of patients. Interestingly, both people with positive and negative troponin had an increased T1 and T2. So most echo and CMR studies in the acute COVID setting in highly selected patient populations confirmed variable prevalence of cardiovascular involvement. But more concerning were initial reports of high prevalence of longer-term cardiovascular effects. Puntman and colleagues evaluated 100 patients who were recovered from COVID-19 using CMR 71 days from illness. Cases included mostly mild COVID, but included the whole spectrum of disease severity with 33% hospitalized. The authors included age and sex-matched controls in addition to risk factor matched patients. 78 of the 100 patients had abnormalities on CMR. In those with hospitalization, 15% had troponin levels above the upper limit of normal during the hospitalization, and 5% had troponin above the upper limit of normal at the time of the CMR. Regarding cardiac function, the authors found that slightly lower mean values of LV and RV ejection fraction were present in COVID-19 patients. Note, however, that mean values were still within normal limits. Overall, 3 main CMR abnormalities were described in COVID-19 patients. The most prevalent abnormality was myocardial inflammation, defined as abnormal native T1 and T2 measures, detected in 60 patients recently recovered from COVID-19. That's 60%, followed by regional scar and pericardial enhancement. There were greater proportions of patients with ischemic, that's 32% versus 17%, and non-ischemic, 20% versus 7%, late gadolinium enhancement patterns than the risk factor matched control group. 22% of patients had pericardial enhancement and 20% pericardial effusion. Huang and colleagues retrospectively analyzed CMR from 26 patients recovered from COVID-19 in Wuhan, China, with moderate to severe acute illness. In particular, the patients included in the study reported cardiac symptoms after being discharged, including chest pain, palpitation, and chest distress. 15 of these 26 patients, or 58%, had an abnormal MRI scan. Myocardial edema on T2-weighted images was present in 14 patients, or 54%. Late gadolinium enhancement was present in 31%. Lower RV function was found in patients with positive conventional CMR findings. Here are some example images from this series from Wuhan. On the left, we see a 29-year-old male after COVID-19 recovery. The MRI was obtained 1 month after the onset of palpitations. Several subtle areas of late gadolinium enhancement are seen in the septum and inferior wall of the left ventricle. On the right is a 60-year-old male, 2 months after recovery from COVID-19 and new onset of palpitations. Late gadolinium enhancement, native T1 and T2 map abnormalities were present. Following the alarming findings of these studies on the longer-term cardiovascular effects, following the entire spectrum of COVID severity, we took advantage of the UK Biobank resource with 310 participants that had CMR scans before the pandemic as part of the imaging visit. 70 of these were amongst the first wave of COVID-19 cases, of which 80% were hospitalized. We found that pre-existing adverse CMR phenotypes, like LV stroke volume and global longitudinal strain, GLS, were associated with greater odds of COVID-19 positivity, independent of classical cardiovascular risk factors. We concluded that observational reports of cardiovascular involvement after COVID-19 may, at least partly, reflect pre-existing cardiac conditions. To investigate in more detail the reported high prevalence of cardiac involvement following even mild COVID-19, this study was initiated. Using the COVID consortium led by my colleagues James Moon, Charlotte Mannersby, and Tom Tribal, we wanted to assess the 6-month impact of mild COVID infection on the cardiovascular system using a detailed CMR scan, including assessment of cardiac structure, function, and tissue characterization. 149 healthcare workers underwent the same CMR protocol, and half of the healthcare workers had suffered from mild COVID-19, and the other half had not had COVID-19. Cardiovascular abnormalities were observed, but were no more common in seropositive versus seronegative healthcare workers post-mild SARS-CoV-2 infection. Some of these CV abnormalities may thus have been pre-existing. Now, there was more reassurance about the longer-term cardiovascular effects after mild COVID. How about more severe COVID-19 infections? Kotecha and colleagues presented this important study of severe COVID-19 in the European Heart Journal. They recruited 148 patients with severe COVID, all troponin positive during hospitalization. CMR scans were performed for clinical reasons and occurred a median of 56 days after discharge from hospital. A historical control group and healthy volunteers underwent a comparable CMR protocol. The table shows that there was broadly little difference in CMR findings between the groups, except mild alterations of RV function. Again, very reassuring. The authors concluded also that pre-existing cardiovascular alterations may have been present and could not be excluded, as no pre-COVID scans were available. Similar story of change in perception in athletes. Initial alarming findings have been moderated through more recent, larger studies. The prevalence of COVID positivity can be very high for athletic teams due to close congregation of players, for example, involving all the basketball players at the University of Houston. On December 12, a star player at the University of Florida collapsed during a game, reported in the press to be due to COVID-19 related to myocarditis. For these high-performance athletes, patient management becomes an issue. There are almost 500,000 college athletes in this NCAA competition. Most are currently receiving routine screening for COVID-19, often at weekly intervals. Initial reports have raised concerns about the safety of athletic professionals returning to sports after COVID-19. The first publication was from Rajpal and reported a small case series and raised the issue of COVID-19 infection in athletes at Ohio State. The authors described CMR in 26 athletes. None had been hospitalized, 12 had mild symptoms, and 14 had asymptomatic COVID-19 infection. The ECG and echo were normal in all athletes. None had troponin elevation. The authors reported 4 of 26, or 15% of athletes, had CMR findings meeting the Lake Louise criteria for myocarditis. 12 of 26 athletes, or 46%, had late gadolinium enhancement, but just 4 of these also had T2 edema showing in these images. Pericardial effusion was present in 2 athletes. This is a larger CMR case series of 145 athletes recovered from mild COVID conducted by Starakova and colleagues. None of the athletes were hospitalized. Most were with mild symptoms and all had normal echocardiograms. 2 athletes, or 1.4%, met Lake Louise criteria for myocarditis, indicating a low prevalence in this cohort of mild infection. Non-specific late gadolinium enhancement was very common in the athletes at the inferior RV insertion point in 26%. Next, even more reassuring findings in this large multi-county case series in the US. 19,378 athletes tested for SARS-CoV COVID infection. 3,018 tested positive and underwent cardiac evaluation. Abnormal findings suggestive of SARS-CoV-2 cardiac involvement were detected by ECG in 0.7%, cardiac troponin in 0.9%, and transthoracic echo in 0.9%. Definite, probable, or possible SARS-CoV-2 cardiac involvement was identified in 0.7% of the athletes, including 0.5% who underwent clinically indicated CMR scans. The authors conclude that SARS coronavirus 2 infection among young competitive athletes was associated with a low prevalence of cardiac involvement and a low risk of clinical events in short-term follow-up of a median of 113 days. Now, to a fairly recent development of concerns of myocarditis cases to be associated with messenger RNA COVID-19 vaccines. Only a few days ago, I received this email from the ACC Advocacy Committee highlighting that the Centers for Disease Control and Prevention identified a likely association between the Pfizer and the Moderna mRNA COVID vaccines and cases of myocarditis and pericarditis. However, the signal is low, with over 1,200 documented cases and over 150 million people having received these vaccines. I will share a few slides with you now that underpin this recent CDC statement. You can find the slides by following the QR code on the slides rather than this lengthy URL code at the bottom of the slide. The good news for the CMR community and patients is that CMR features both in the definition of probable and of confirmed myocarditis diagnosis. It's important to remind ourselves that in adults, the prevalence decreases with age and is far more common in young men, as you can see on the right-hand graph. The next 2 slides show you 4 early reports of myocarditis after messenger RNA COVID-19 vaccine. Marshall and Rosner reported United States data. Marshall described 7 healthy males, 14 to 19 years of age, within 4 days of the second messenger RNA vaccine, all with abnormal troponin, ECG, and MRI. Treatment was with NSAIDs alone in 3 and IVIG and steroids in 4. All were discharged to home after 2 to 6 days in the hospital with a median of 4. Rosner and colleagues reported 5 males, 19 to 39 years of age, within 4 days of the second dose of the vaccine. One 24-year-old male, 7 days after the first dose. All presented with abnormal troponin and MRI findings. Varying ECG findings were seen. Treatment was again with NSAIDs or colchicine in 4, beta blockers in 2, and steroids in 1. All were discharged home after 2 to 4 days in the hospital. Note that there was a spike protein antibodies were negative in patient who presented after the first dose. International reports were from Larson in Circulation, who reported 8 males, 22 to 56 years of age, 4 in the US and 4 in Italy, 7 within 4 days of dose 2, 1 with onset 2 days after dose 1, but he had a history of prior SARS coronavirus 2 infection. All with abnormal troponin, echo and MRI, and 7 out of the 8 with an abnormal ECG. Again, treatment with NSAIDs or colchicine in 4, steroids in 2, and no treatment in 3, and all were discharged home with resolution of symptoms and preserved ejection fraction. The Israeli Ministry of Health reported 148 cases of myocarditis occurring within 30 days of mRNA vaccine. 27 cases came out of the 5.4 million first doses and 121 cases out of approximately 5 million second doses. So mostly in men aged 16 to 30 years of age, and most were in the hospital up to 4 days, and 95% of cases were considered mild. So in summary, myocarditis is rare in the context of mRNA vaccination. Treatment is largely supportive. Myocarditis after messenger RNA vaccines is mostly occurring in males under the age of 30 years within a few days after the second dose. And early data of acute outcomes of myocarditis after mRNA vaccines have been good, but no long-term data is available yet. Similar position statements have now come out from the European Medicines Agency, or EMA. The Society for Cardiac MR, or SCMR, have provided advocacy by stating the importance of CMR in diagnosing myocarditis. So let's consider some take-home messages. Cardiovascular disease increases the risk of severe COVID-19 presentation. Cardiovascular manifestations may occur during the acute phase of COVID, and cardiac involvement seems associated with COVID-19 severity. Evidence suggests sustained cardiovascular involvement is uncommon. Even if patients have scarce structural and functional abnormalities, this is no different to carefully matched control groups in the entire COVID severity spectrum. Cardiovascular involvement in athletes after COVID is rare, and there may be a link between messenger RNA vaccines and myocarditis, but the clinical course seems benign, but more evidence is needed. Here I list study design and other considerations which I believe partly explain why we have seen shifts in perception of the gravity of COVID impact on the heart. That includes selection bias, publication bias, science communication, and by that I mean that we've seen shifts from the typical pre-publication peer review to maybe a faster peer review and then followed by post-publication peer review. And I think this shift will not go back to normal to prior the pandemic. I think that's probably a good development, having options of post-publication peer review. Next, the importance of carefully selected control groups has been highlighted. And I think the ideal control group, but that's difficult to do, would be patients with systemic inflammatory conditions without COVID. We need to consider pre-existing abnormalities when no pre-COVID imaging data available. We need to consider the clinical relevance of non-specific CMR abnormalities like RV-LV insertion point-led gadolinium enhancement. And the COVID pandemic and the impact on the peer review for publications, post-publication peer review. This is what I've already mentioned. So what's next? We collated planned and ongoing studies using CMR to investigate cardiovascular manifestations of COVID-19. We identified them primarily via clinical trial registration sites. CMR is mainly used in these studies due to to the accuracy, reproducibility, and the ability to characterize myocardial tissue. A total of over 10,000 participants will be enrolled in 31 studies. These will be performed to address a range of questions in a range of settings and patient populations. I would like to mention one study that is unique, UK Biobank's COVID-19 repeat imaging study, where participants who within the UK Biobank imaging assessment visit before the pandemic have been recalled for a repeat imaging visit, with half of the participants having been infected with SARS-CoV-19 and half not. This allows a powerful case control before and after study with a very large sample size. I would like to thank the organizers for inviting me to speak to you about this important topic. I would like to thank you for your attention, but would really like to thank the co-authors listed here of a review article on this topic which is under consideration at the time of recording. In particular, I would like to thank you all for the fruitful discussions via MS Teams, and in particular for David Blumke, coordinating the effort, and Zara Rezi-Esterbrak and Elisa Rausio for helping with the content of this presentation. Thank you.
Thank you, Professor Peterson, for an excellent talk about a timely topic. So the last speaker is Tim Liner, whose title is the non-contrast CMR applications. Dr. Liner is a professor of radiology at Utrecht University Medical Center in Utrecht, the Netherlands. He was a past president of the Society of MR Angiography, and he is a core leader of SCMR, ESCR, SCCT, ECR, and RSNA. He is currently a president of ISMRM, and so we might have met at the Nantes, France, 2 years ago, the MRA club meeting. So, Dr. Liner, please start your presentation.
Good morning and welcome to the second day of Asci 2021. My name is Tim Liner, and today I will talk about non-contrast CMR applications. I'd also like to thank the organizers again for inviting me to give this lecture. These are my disclosures. And what I want to do with you is I want to walk you through the different non-contrast MRA techniques in this lecture that are currently used, and these concern techniques that are used for imaging the heart as well as the vasculature in the body. What I then want to do at the end of the lecture is I want to talk with you about several up-and-coming new technologies that you may have also seen in my lecture yesterday. So when you're interested in this topic, this is an excellent review of non-contrast CE MRA techniques. And again, this doesn't only refer to vascular imaging, but also applies to cardiac imaging. So this is a paper written by two pioneers in this field, Bob Edelman and John Koktsoglu from Chicago. And they have done an outstanding job in summarizing the current state of the art in this very recent paper. If you photograph the QR code, it'll take you right to the link where you can download this paper. So let's take a look at these different non-contrast MRA techniques. So basically there are two different families that we can distinguish. First, there's the flow-independent techniques, which basically consists of balanced SSFP techniques. And then this is complemented by inflow-dependent techniques. And here's more variety in terms of different technologies. So there's non-subtractive techniques, there's subtractive 3D MRA techniques, there are 2D, 3D, and 4D phase contrast techniques, well known to everyone, and velocity selective 3D MRA techniques. So this is basically the landscape of non-contrast MRA. And now let's take a look in a little bit more detail at all of these different techniques. So the flow-independent techniques, as mentioned, primarily currently in clinical practice consist of balanced SSFP-based techniques. The premise of this technique is that it relies on intrinsic contrast of blood versus surrounding tissue. T1 of blood is 1400 milliseconds and T2 about 250 milliseconds at 1.5 Tesla. And the nice thing is that this can be combined with techniques like fat suppression using either spectral pulses or Dixon techniques. It can be paired with T2 preparation, and it can be paired with cardiac triggering and respiratory compensation if we're imaging structures in the chest. And these techniques are outstanding for imaging the aorta, the pulmonary veins, cardiac anatomy, as well as the coronary arteries. So the advantages of these techniques, or this family of techniques, is that it is very good at depiction of slow flow in veins and diseased arteries. The disadvantages are that this technique suffers from off-resonance artifacts. So what you need to do here is you need to maximize the sampling bandwidth. You need to scan with the shortest possible TR, and preferably you need higher order shimming. Here's an example of this technique. So this is a 44-year-old male with a status post-aortic, ascending aortic replacement, and you can nicely see that the motion of the heart can be completely frozen, and the cardiac chambers, as well as the ascending aorta and the aortic root, as well as all the large vascular structures in the chest, can be depicted with high fidelity in 3D high spatial resolution, which offers ample anatomical detail for post-operative evaluation, or preoperative evaluation, if you will. And obviously this can be combined with conventional cardiac evaluation if needed to assess other aspects such as cardiac function. So this is cardiac triggered, so synchronized to diastole, and it's also respiratory navigator gated, which means that we take into account motion of the diaphragm, and this is synchronized to end expiration because that leads to the most reproducible position of the heart and the vascular structures in the chest. So post-acquisition, we can make reconstructions in different anatomical orientations. Again, this is a 3D technique, so the images are reconstructible in many different orientations for making all the different measurements to follow up the aortic root dimensions, for instance, and the aortic valve. In this case, you can also see this little black jet going back into the left ventricular outflow tract, showing that there's a little bit of aortic insufficiency here. And this is a different cut through the same data set. Coronary anatomy can be depicted very nicely using this technique, as you can see right here in this LAD orientation or curved MPR. So you can nicely see that if you increase the spatial resolution compared to the previous patient that I showed you, you can also nicely depict the coronary arteries. And there's now a substantial body of evidence that the quality is nearly comparable to coronary CT. Of course, this technique takes longer, and the main indication here is the depiction of coronary artery anomalies and not coronary atherosclerosis. All right, now let's move on to the second family of techniques, the inflow-dependent techniques. And as I mentioned, there are different techniques in this family, 4 different techniques, so let's look at them in a little bit more detail here. So we have the non-subtractive techniques, time of flight and IFDIR. And time of flight is well known, of course, primarily used in the brain, and inflowing blood here generates high signal, and the background is saturated by many RF pulses. This can be done in 2D and 3D acquisitions, and the IFDIR means inflow-dependent inversion recovery. This is a 3D balanced SSFP readout preceded by an inversion pulse to suppress the background. And this technique is successfully used for imaging the renal arteries. Advantages of this technique is that there's lots of experience. Disadvantages are in-plane saturation using primarily the time of flight techniques, limited depiction of vessels in patients with slow or triphasic flow, so that's actually quite a limitation, and it's sensitive to irregular breathing. Here are a couple of examples. Time of flight, well known and of high value for imaging brain vasculature with high fidelity, beautiful depiction of even the smaller branches in the brain as well as on the outside of the skull. Carotid artery imaging is also still done with time of flight in many cases, and it can nicely show the luminal narrowing as good as CTA can with current techniques. The spatial resolution is comparable. This is IFDIR, and as I mentioned, this technique has been used successfully in imaging the renal arteries, and you can see right here in this patient with a renal artery stenosis on the left that on the right side you have this bright signal where the blood nicely distributes into the right renal artery, but in the left renal artery you can nicely visualize this high-grade stenosis quite accurately in comparison to the reference standard technique, DSA. This is another view of the same data set, and again, if you use adequate spatial resolution, the technique is really reliable. This is the reference standard DSA, which shows identical degree of stenosis compared to the MR. Another very successful technique is the non-subtractive KISS technique, quiescent interval slice selective MR angiography is what it stands for, and this is a slice selective acquisition with an in-plane saturation pulse to suppress the background. Also, what is used in this technique is a tracking RF saturation pulse to suppress venous signal. This is combined with fat saturation to remove the tissues with short T1, i.e. fat, and then a quiescent interval is taken into account after these saturation pulses are applied to replace saturated blood spins with fresh spins, which then give a strong vessel to background contrast. This is a fast technique, single shot readout. It's very insensitive to motion, and this technique is scanned in blocks of about 15 centimeter coverage to minimize off-resonance artifacts. And depending on the anatomy, one or more blocks can be used to acquire the anatomy that one wants to see. Advantages here are there's very little preparation, it's a fast acquisition, there's no in-plane saturation due to the quiescent interval. It can be used for venous imaging by flipping the saturation band and increasing the quiescent interval to accommodate the slower flow, and it is compatible with breath holding. If there are motion artifacts, it can corrupt only one block of slices at a time. Disadvantages are it's not an isotropic 3D technique. It has a lower spatial resolution in the slice orientation, and it is sensitive to off-resonance artifacts. Here's some examples given to me by Bob Edelman, the pioneer of this technique, and you can see beautifully that compared to the CTA on the left, the KISS acquisition shows near identical image quality. And on the right side, we can see a contrast-enhanced MR angiogram of the peripheral vessels. And if we walk down the vascular tree, you can also nicely see that the collateral circulation is depicted with high fidelity all the way down to the feet. So very powerful technique. Signal loss here due to the slice thickness. So I mentioned that as a limitation, but this is something one can live with, I think. Here's another example of a patient with PE. You can nicely see the PE right here in the right lower lobe artery. And this nicely confirms or is confirmed by the CTA in this case. So this can also be used not only for peripheral vessels, but also for evaluation of vessels in the chest. Central PEs. The third technique is subtractive 3D MRA techniques, cardiac gated subtractive techniques using 3D fast spin echo. Flow sensitive dephasing and arterial spin labeling are all techniques that are members of this family, if you will. They are slightly different in the technical implementation, but they're very useful in clinical practice these days. So here's some examples. This is a arteriovenous malformation in the brain, and you can nicely evaluate the feeding arteries and the draining veins when looking at this trans image. This is the Phillips term for subtractive 3D MRA non-contrast. So this is courtesy of Nagoya Daini Red Cross Hospital in Japan. Here are some images of the peripheral vasculature. So this technique works by acquiring a diastolic image in which the vessels are filled with blood and have high signal intensity. What we do is we subtract a systolic image where there's flow dephasing, and what is left is a suppressed background with bright arteries in this case, which allows for a nice evaluation of the peripheral vasculature. And again, this technique can also be used in other anatomies, such as the upper legs, the pelvis, and the chest. Phase contrast. This is quite an old technique. It is used routinely, of course, in cardiac imaging to measure flow, and it can be used as a 2D acquisition, a 3D acquisition, but also a 4D acquisition, which is basically a cine volume, which is commonly known as 4D flow and is now starting to be evaluated for many different indications in the chest and outside of the chest. The drawback of this technique, last technique, is that it has somewhat lengthy scan times, and it is better with contrast agents if high spatial resolution is desired. And also there's somewhat complex post-processing, but the information can be very useful and very revealing of certain pathologies or flow patterns. Here's an example. This is 2D phase contrast. So at the level of the ascending aorta, we can nicely see the flow coming towards us in the ascending aorta and going away from us in the descending aorta. And we know how to analyze this for flow volume analysis and also for determination of regurgitant volumes. 4D phase contrast, known as 4D flow or 7D flow, is again very useful. It allows measurement of flow in every pixel over time in different flow orientations, and we can make these beautiful maps that can show us the distribution of flow, vorticity, helicity, all kinds of advanced flow parameters, and energy loss parameters can be calculated from these images that may allow for advanced evaluation and therapeutic planning of patients with a variety of different vascular and cardiac conditions. Here's an example of a patient with a post-aortic switch operation where you see the typically dilated aortic root with a vertical flow period pattern in the aortic root. Here's another example, courtesy of Michael Markle from Northwestern University, a pioneer of this technique, showing you the flow in this ascending aorta and descending aorta. And again, the nice thing here is you can measure flow in different orientations and planes by simply taking a plane and putting it at a certain place in the scanning volume and measuring everything post hoc. So there's no more problems with planning or misplanning the 2D orientations of the slices. Velocity selective 3D MRA is the last technique. This is a technique that generates vessel background contrast based on the velocity of spins, and it overcomes limitations of slow flow. However, it's sensitive to B0 and B1 field inhomogeneity and thus demands shimming and pulse sequence design considerations. Here's some images. This is a paper that was published not so long ago that nicely shows velocity selective imaging on the left versus FDIR imaging in the middle and on the right. So here is again the summary of the different families of techniques that I started out with. And this brings me to a review of some future developments that I want to finish the talk off with. So we've now focused on imaging anatomy and using intrinsic contrast of blood or the flowing properties of blood to depict anatomy. So I think in the near future we'll also see some developments in the field of contrast-enhanced imaging, for instance, in the context of imaging myocardial scarring, and that's what I want to talk about in the last couple of slides. So a very powerful technique that's gaining more and more interest is radiomics, and in this paper by Bessler et al., the investigators looked at the capability of radiomics or texture analysis to identify scar tissue in the left ventricle. So what they did is they took a data set of 120 patients with scars, 72 patients with large infarcts, 48 with small infarct, and 60 control subjects. What they did is they used conventional late gadolinium enhancement imaging in all of these patients to determine the presence or absence of scar and the extent. And what they then did is they took a single M-diastolic cine frame and ran a texture analysis package on this slice. And the objective here was to acquire or to basically identify subtle differences in the grayscale values and use this to detect scar tissue. So they used an open source software package, and they were actually quite accurate at picking up these scars using this technique. Both large scars and small scars could be imaged with very good accuracy. The area under the curve for both of these types of scars exceeded 0.9. Now, the final example I want to show you is this work by Jean et al. Very nice work that used machine learning or deep learning for the diagnosis of chronic myocardial infarction using motion patterns of the left ventricle. And what these authors succeeded in doing was identifying subendocardial MI as well as transmural MI in 212 patients and 87 controls without the need for gadolinium injection. Of course, gadolinium enhanced imaging was used as the reference standard in this study. And as you can see right here, these authors were also very accurate in identifying myocardial scar, but without the need for contrast injection. So I think this is also going to be a very nice addition to the toolbox in the near future. So that brings me to the conclusions of this lecture about non-contrast CMR applications. So there's a variety of different techniques that are each suited for different indications that either use intrinsic blood to background contrast or flow-dependent techniques that allow for imaging different anatomies and different vascular territories and pathologies. So the choice of technique obviously depends on the clinical question. For carotids and cerebral arteries, time-of-flight techniques are very well suited. For the heart and thoracic vessels, balanced SSFP techniques are great. For renal and abdominal arteries, IFDIR techniques are great, and for peripheral arteries, KISS techniques and TRANS techniques are great. Of course, there is overlap between these different methods and the different anatomies, and in the next years or next couple of years, we'll see much more papers coming out evaluating these techniques versus reference standard techniques that we use right now for the evaluation of different pathologies. New developments are the application of radiomics and AI-aided techniques for replacing contrast-enhanced scans. With that, I'd like to thank you for your attention. I want to refer again to this non-contrast MR angiography update paper, which is a fantastic resource. And this ends the lecture.
Okay, so thank you, Professor Tim Lehner, for the nice presentation. So in the last part, we have 20 minutes to the discussion and ask the speaker. So now I have a first question for Professor Joachim. Can you hear me? Yeah, okay. Here's the first question. What is the role of CT in diagnosis? ARVC, can it supply a CMR from the Professor Minh Chinh Wu? Please.
Thank you. We discussed this in the chat already. CT and ARVC, of course you can do it, because the only thing is you need to have a retrospective gating to look at the subtle changes in wall motion. That's the main problem. And if you know that ARVC patients usually have tachyarrhythmias or arrhythmias, it might get really worrisome to do this in the CT. But if no other choice because of, you know, implanted intraventricular devices, CT might go, yes.
Okay, thank you. I have a question for you. It's related to the COVID-19 and myocarditis. And what do you think about the cardiac safety aspect in COVID-19? And the second question is sometimes we cannot diagnose differentiation between the acute MI and the acute myocarditis because it's a similar pattern. So can you, in that case, we can do the coronary angiography or not? Thank you.
When I understood it correctly, if the question is whether there are any safety aspects concerning COVID-19 and CMRI, no. There is no problem with increased sensitivity of the myocardium due to COVID-19. You have to keep, of course, the security measurements for the techs and the room environment for COVID-19, so FFP2 or oxygen mask with expiration filters. Otherwise, then no problem. We, as I wrote in the chat, we do not really have the differential diagnosis very often in COVID-19 patients between infarction or myocarditis. So more or less, we have the questions of myocarditis-induced changes within the myocardium. So, and as we heard in the talk, this is readily the picture you expect. So myocarditis-like changes within within COVID.
Yeah. Okay. Here's the question from the audience for the Professor Loss. In your experience, how can we differentiate ARVC from the non-compaction of right ventricular myocardium on CMI?
Yeah, that is a very interesting question. And thank you very much for this question. As I wrote in the chat, we do not have any experience with a non-compaction right ventricular cardiomyopathy, and we'll look into the literature about this because the right ventricle is a hugely trabeculated part of the heart, and so we have no experience with that. So, but the more questions I think how you differentiate the different right ventricular cardiomyopathies, and this is rather tricky. So we know it's a huge variation of cardiomyopathies of the right ventricle. ARVC is only one of them, and if it's really of clinical significance for the therapy, myocardial biopsy and genetic phenotyping is the way to go.
Okay.
Thank you.
Do you have any question? I have a question for the Professor Tim Lehner. Okay. In your experience, what do you think about the clinical indication of the non-contrast coronary MRI angiography sequence in real condition, especially in the ischemic heart disease, now and the future?
If I understood you correctly, I think you were asking what is the role of non-contrast MRI?
Coronary MRI.
Yeah, well, I think what I've shown in my lecture is that there are a number of very powerful techniques. I think some of them are still being used in somewhat of a research setting, but I think we've seen a lot of literature being published in the last couple of years that show the clinical potential of these techniques. I know that some of them are available on the scanners of the large vendors. I know that Philips and Siemens are very much working on this, and they have commercial products that you can buy. I think the results are okay, but not perfect yet. In my own experience, we have used non-contrast MRA very successfully using the balanced SSFP techniques for the large vessels in the chest. So we don't use contrast-enhanced MRA anymore, especially in younger patients for this indication. We do large vessel imaging of the pulmonary arteries, the aorta, post-operative evaluation, things like that. We find it to be very reliable. The advantage of using contrast is, of course, the speed. It's much faster. So you get a quick angiogram, which is quite nice. That's very fast and reliable. We have more experience with those methods. So that is let's say, the balance I think we're in right now with regard to this field. I think that, for the chest, you could even say that the non-contrast methods are better because the contrast-enhanced methods are typically not cardiac triggered, which leads to blurring of the aortic root and the vessels very close to the heart. So that's actually a disadvantage of using contrast there. So I hope that answers the question.
Yeah. Okay. Thank you, Professor. Do you have any question or comment from audience? So if there are no questions or comment, I would like to announce the closing of this session. Thank all speaker participants and co-chairman, Professor Mochizuki. Thank you and have a nice day. Yeah, thank you.
Bye-bye.
Bye.
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 To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.